PC is a 43-year-old woman presenting to the emergency room with headache, bilateral hearing loss, bi from Latin meaning two and lateral meaning sides, and she had diplopia, diplo from Greek meaning double, and opia referring to a visual disorder. She had double vision in both eyes. 2 months ago, something was wrong. She had a unilateral headache, uni meaning one, it was just on her left side. But it was a pain that she had experienced before, she thought. 15 years earlier, when she was 28, she had an episode of shingles. This is a time when chickenpox is reactivated. PC is 43 right now. This is happening in year 2022, meaning that she was born in the late 1970s, a time when 99% of children got chickenpox. Varicella-Zoster virus causes chickenpox, which later in life can reactivate to shingles, also known as herpes zoster. And it gets into the nerves, causing very painful symptoms, one of which is a particular feeling headache. At the urgent care, given this history and her symptoms at that time, they give her a 1-week course of antiviral medicine, and the headache went away. So they tried that medicine again for this presumed second shingles episode 15 years later, and it resolved the headache at the time, but something else was wrong. 1 month after the headache, which is 1 month before she's presenting to the emergency room now, PC started having tinnitus, a ringing in her right ear. She just woke up one morning with the horrible sound blasting on that one side, but then her left ear started ringing too, and both her eyes became bloodshot red. At the otolaryngology clinic, ears, nose, throat doctor's office, PC was found to have something going on, but nothing was conclusive. Her auricles and her external auditory canals were normal. Hearing tests confirmed she had hearing loss, but reasons why were not found. An MRI of her head showed nothing wrong. PC was diagnosed with sudden idiopathic hearing loss, idiopathic meaning of an unknown cause. She was given a 12-day course of steroids because many times this could be inflammation related and things seemed to be fine at first, but 4 weeks later, it was only getting worse. The ears help maintain balance. They do this through fluid-filled semicircular canals that contain sensory cells. This is called the vestibular system. It relays signals to the brain. One of the first things that the doctor noticed was that PC's balance was totally off, and a repeat hearing test found that her hearing had gotten much worse over the last few weeks. Given that balance is ear-related and that her hearing has gotten worse, then it means that something very terrible is happening. It could be wrong with her nerves, it could be something wrong with her brain. She was given an urgent referral to a rheumatology clinic, one who specializes in autoimmune diseases, and they set the schedule to see her in just 3 days, but she wasn't going to make it to 3 days. Hey, have you learned something from this video so far? If you have, and you're not subscribed yet, I'd really appreciate it if you did subscribe and come back to see the video that I publish next month too. I've made, on average, 1 video a month, every month since 2017. I do these videos for fun, and they're to teach medicine by showing cases and their associated stories. Your time is one of the most valuable things that you have, so I want to make sure that it's worth your time to watch every time. And I always enjoy making these. Thanks so much. Appreciate you. PC had polyarthralgia, poly meaning many, and arthra referring to joint, algia meaning pain. Her entire body hurt. She started seeing spots in her field of view. Her head was pounding so hard she wasn't going to make it to the rheumatology visit. She drives herself to the emergency room, where we are now. At examination, PC physically looked fine. A blood test finds she has some kind of inflammation happening. Every other everyday vital sign was fine. Her blood pressure, heart rate, breathing, all normal, no fever. Looking at her eyes, doctors found inflammation there. At this hospital, they did tests again and confirmed PC did have hearing loss. One ear was worse than the other, and she couldn't balance herself. But it was just these 4 problems. Given her headache, polyarthralgia, asymmetric sensorineural hearing loss with vestibular hypofunction and ocular inflammation, doctors have some clues as to what's happening. They write a list of problems that can cause all of these together, and they need to rule out each one to figure out exactly what's happening. PC's problem started 8 weeks ago with a headache that may have been shingles. 4 weeks if you only count the hearing loss. This pace is important. If these problems came up in 8 seconds instead of 8 weeks, then you would think that the problem is vascular, blood vessel. So with a headache, you'd think stroke. If it was 8 years, you would think of cancer, that a tumor has grown somewhere in her body and has finally manifested its symptoms in a way perceivable, obvious, and rapidly degrading her quality of life. But despite her current problems coming up in just weeks, she did have a suspected shingles reactivation 15 years ago. What if that wasn't shingles? Leukemia can create blood cells that infiltrate nerve tissue, causing sudden hearing loss. Tiny little tumors that have spread all throughout her body can also get in and do the same thing. But there's a very easy way to find out if this is what's happening. Tumors would be in the brain. That means that we could see it on the MRI. And when doctors did a brain MRI, it looked normal. So she doesn't have cancer. But if we know that her problem is inflammation, what else could this be? It could be autoimmune, auto meaning self, but which disease affects the eyes and ears simultaneously like this? Lupus actually can do this, but typically lupus affects eye blood vessels when it does, and she doesn't have that. She also doesn't have other symptoms of lupus. There's a disease where the immune system inflames the spine completely, disabling a person, known as ankylosing spondylitis. In the immune overreaction, this can cause permanent hearing loss, but when it affects the eye, it typically only affects one at a time, and she doesn't have anything wrong with her spine. Every single autoimmune problem that PC could have would exhibit hearing and vision loss in ways different than what she has. And she also doesn't have any of the disease-defining problems of any of these except for one. So this is marked as a maybe. The only way that it could be this is if it isn't anything else. Which brings doctors to the final inflammation category, infection. Lyme disease. It's caused by a bacteria named Borrelia burgdorferi that comes from a tick bite. PC is in Michigan. Michigan has ticks. Lyme disease causes polyarthralgia, vision loss, hearing loss, and vertigo. Borrelia is a spiral-shaped bacteria called a spirochete. Doctors sent PC's blood samples to test for this. But a different spirochete that also causes all her symptoms but forms an entirely different disease is Treponema pallidum, the bacteria that causes syphilis. Because PC is having neurologic signs and symptoms, doctors stick a needle into her back to draw some of the fluid that cushions the spine and the brain called the cerebrospinal fluid, CSF. If her problem is syphilis, then it means that the bacteria has gotten into her brain. And when the tests returned, they found out PC has syphilis, but something was wrong. When doctors found syphilis, they reported it to the Michigan Disease Surveillance System. And when the Michigan Department of Health and Human Services got the report, they immediately opened an investigation because there was much more to this case. 5 weeks earlier, a 50-year-old woman presented to the emergency room with blurred vision. She was in a panic because she was scared that she was going blind. There were multiple sores between her legs. Her primary care doctor believed this to be a herpes simplex virus reactivation, but in the hospital, they found out that wasn't herpes, she had syphilis. When they asked her about intimate partners, she gave the name of a man that she had met on the internet 2 months earlier. She didn't have any close contact with anyone else for more than 12 months prior. 2 weeks later, in the same emergency room, a third person, a 60-year-old woman, presented to the emergency room with hearing loss, blurry vision, and double vision. She had trouble moving her eyes. Her face was drooping. They thought she was having a stroke, but physical exam found lesions between her legs. And when they tested further, they found out this woman also had syphilis. When they asked her about intimate partners, she gave the name of a man she met on the internet 2 months earlier, and she also didn't have any close contact with anyone for years prior. The reason why Michigan Department of Health and Human Services opened an investigation is because the name of the man given by these 3 women was the same. All 3 women had met him with close contact in just the time span of a couple of weeks. Public health officials called this man. He picked up, but he didn't have much to say. They scheduled a visit for him to come in and see one of their public health doctors, and he agreed to a set time and day, but he didn't show up. A couple weeks pass. At an emergency room in another southwest Michigan county, a 45-year-old woman presents to the emergency room with blurred vision and a rash on her hands. The inflammation in her eye looked very particular. When they tested her, they found syphilis. She had had close contact with 3 people in the last 6 months. 2 of the men tested negative for syphilis, and when she gave the name of the most recent person, it was the same name as given by PC and the 2 other women. And it still wasn't finished. At yet another emergency room in a neighboring county, still in Michigan, a 51-year-old woman presented with visual floaters, seeing flashing lights and worsening vision. These came 3 months earlier when she had cataract surgery, so they thought maybe that was responsible. But not even a few weeks later, when this woman came in with headache, confusion, and stiff neck, they found out that she had syphilis. And when they asked her about recent intimate contact, she listed a few names, one of which was the same name given by PC and the 3 other women, all of these cases tracing back to the same person. Syphilis, as we know it today, was first documented clinically in the late 1400s, but humans didn't know that bacteria caused it until 1905. And 92 years after that, Treponema pallidum's entire genome was sequenced. So we happen to know a lot about this particular bacteria, which means when health officials finally got to meet the common intimate partner of these 5 women, they noticed something weird. A local public health physician reviewed this man's medical records around the time PC's case was reported to the state. They found out he had gone to the same emergency room as one of the other women 2 months before he met PC. The medical record logged that he had ulcerative lesions on not only the part between his legs, but he also had a rectal lesion too. He had told doctors here that he had had intimate contact with a 60-year-old woman just the day earlier. This would turn out to be the same 60-year-old woman who presented to the emergency room 3 weeks before PC. When doctors asked further, he stated that he had multiple female partners in the last 12 months, and all of them were women. Typically, early syphilis for men presents as one lesion. It's called a chancre, and that chancre doesn't usually show up immediately the day after. What can show up as multiple lesions much quicker is herpes. And so this man was tested for herpes, but it was negative. Sometimes the test isn't right, and he was discharged with medicines for herpes. No syphilis testing was done. Therefore, the Michigan Disease Surveillance System didn't get the report. And it was from here where he continued to have intimate contact with local women in neighboring counties all along the southwest Michigan region. But this wasn't the weird thing that public health officials noticed. All 5 women had blurred vision and thus ocular syphilis, and this happened just weeks after their initial infection. Syphilis that has systemic symptoms like this quickly should be rare. If it does happen, it's most recorded with HIV co-infection and with male-to-male contact. People who misuse substances by injection are also at risk of getting more severe syphilitic disease, but none of these 5 women fit any of this criteria. All of this, stemming from a single common intimate partner, suggests that an unidentified strain of Treponema pallidum was transmitted here. Data typically hasn't logged majority women to experience this kind of disease, and this is where some connections need to be made. In 2015, Seattle, 4 men were reported by local hospitals to have come in with vision loss. They were diagnosed with uveitis, itis meaning inflammation of the uvea, the middle layer of the eye's outer wall. Further testing found all 4 had syphilis. They were men who had intimate contact with men, and 2 of them knew each other. They were partners. 3 of these patients recovered some eyesight after syphilis treatment, but 1 was permanently blind. 2 months later in San Francisco, 8 patients with ocular syphilis were reported to CDC. 1 was a woman, 7 were men, of which 6 had intimate contact with other men, and only the straight man did not have HIV. 7 patients recovered some vision after syphilis treatment, and 1 was permanently blind in one eye. In 2015, syphilis cases in the United States had been rising for 15 years. It would continue to go on higher. Before 2015, CDC didn't have a good way to record ocular syphilis. In fact, PC's situation where her hearing loss was diagnosed as idiopathic, that there was no known reason for the hearing loss, well, there was an ocular version of that was happening to syphilis patients at the time. An eye doctor would just treat the uveitis without finding the patient's underlying syphilis, or the patient, just under the notion that they might have an eye infection, could have just taken treatment that did nothing for the syphilis, and then gone on to have intimate contact with more people, passing on the treponema before becoming permanently blind. So in 2016, following these reports, CDC issued a clinical advisory and an easier way to report ocular syphilis. And this is where we will start hypothesizing. Do you remember that we sequenced Treponema pallidum's genome in 1998? Well, since then, we have a decent idea of what strains are around in different regions in the United States. In 2016, 63 patients with syphilis in Seattle gave samples where Treponema genome was sequenced. They wanted to see if ocular symptoms were being caused by a specific strain. 18 of them had ocular syphilis, and from them, at least 5 distinct strains of Treponema were identified, of which 1 unusual strain was detected, different from the other ones with and without ocular syphilis. On its own, this study didn't find clear evidence that this increased incidence of ocular syphilis was absolutely 100% because of an unknown strain. But newer evidence since then suggests that the bacteria is changing in a way that we've never seen before. In 2023, a 32-year-old man in Seattle came into the emergency room with fever and purulent urethral discharge. Purulent meaning that there was pus. He told the admitting nurse that he had an intense pain between his legs, and all of this came a few days after intimately interacting with a woman, different from the woman who he lived with and normally interacted with. And he said that woman he lived with was newly diagnosed with HIV 4 weeks earlier. This particular man was newly diagnosed at this emergency room visit with acute HIV. They found a single chancre between his legs, and unlike the 5 women from Michigan, he was tested for syphilis right then and there, and it came out positive. He was given antibiotics in the emergency room and given additional antibiotics to take home. These would clear out the treponema and prevent syphilis from progressing further, and he was scheduled for an appointment to start HIV treatment, but he never showed up for that appointment. Over the next 15 months, this man would be in and out of urgent care in the emergency room. He'd have severe abdominal pain, blurred vision, and a shooting pain up his leg, but every time, just before they would treat him, he would leave. 18 months after his initial diagnosis, the symptoms were so severe that this man presented to the emergency room. By this point, he had lost 40 pounds, lost most of his hair, and he had become blind in his left eye. When doctors sent a camera down his throat to look at his stomach, they found multiple ulcers. They took samples from these to test, and they found treponema pallidum. Doctors sent another camera through his other end and found inflammation, and they took even more samples. And this is where further evidence that treponema is changing appears. When the treponema genome from this man's ulcers were sequenced, doctors found that there were 2 distinct strains present. This man had told doctors he only ever had intimate contact with women, but he hadn't for several months at this point because he had become so sick, meaning at the time of infection, he may have been infected more than once simultaneously. But also found was that both strains' DNA featured mutations not yet observed, meaning that the bacteria may have undergone intrahost evolution. This might have been from the fact that he discontinued treatment shortly after his initial diagnosis 18 months earlier, and possibly with his HIV co-infection. But all of this led to the most unique finding. Some specific genes were discovered that were a combination of both strains together. You can't get these specific genes without putting these 2 strains together, meaning that both bacterial strains had gathered together and were creating a brand new strain of syphilis through genetic recombination. Given that this man had extreme ocular symptoms to the point of becoming blind in one eye, and that this is happening 8 years after the CDC issued the clinical advisory on ocular syphilis, this is another signal for us to consider that syphilis is changing in a way that we've never seen before. And this brings us back to PC's case. When she was found to have ocular and neurosyphilis, she was given intravenous penicillin. When syphilis is found early and there aren't that many treponema bacteria floating around, it's usually 1 dose intramuscularly. When syphilis is in the brain and the nerves, like in PC's case, the intramuscular dose can't get into the brain, can't get into the nerves, but intravenous penicillin can get in, so it was given every 4 hours for 2 weeks. There are several things that are true that may or may not be connected here. First, syphilis cases in the US have been going up since year 2000. Second, HIV co-infection makes syphilis disease worse because of immune deficiency. Third, the prevalence of ocular syphilis cases appears to be increasing. This may have been happening before the CDC advisory in 2016. However, the increase could also be attributed to the fact that we're paying more attention to ocular syphilis. Fourth, treponema pallidum is changing through genetic recombination. We have documentation going back decades that this particular bacteria changes slowly. But we've now been able to directly observe that different strains can and will recombine genetically to create new strains. It's not to say that this has never happened before, it's just that we now have evidence of seeing it firsthand. These 4 things are not an exhaustive list, there's probably a lot more. But if we look at just these 4 things, a few questions come up. If the cases have been increasing and there's a situation whereby the bacteria can cause a different looking illness in humans, and given that the bacteria can and has changed in ways that we haven't seen before, Is it possible that certain new strains are causing more cases of and more severe ocular syphilis? Will these changes in the bacteria create a different syphilis with different signs and symptoms? And maybe the worst question that we could think of right now, from these changes, can an antibiotic-resistant strain of Treponema emerge? We saw it happen in the early 2000s. Another antibiotic called azithromycin was able to treat syphilis. This was for the patients who are allergic to penicillin. But since around 2002, we can't use it anymore because the bacteria is completely resistant to it now. But that recombination paper from Seattle says that that particular recombined strain didn't feature penicillin resistance. And the question that we might not ever know, because doctors weren't able to take samples from PC or the 4 other women, or from the one common partner they interacted with, is did they have an unusual, undocumented bacterial strain passed among them? One that caused their ocular syphilis of this severity in such a short amount of time? No matter what, we have this case to refer to now going forward. Syphilis isn't going anywhere anytime soon. Public health campaigns have been raising awareness about it, which, by the way, please see a medical professional if you believe you may have been infected, and don't wait and don't pass it on to others. And with research and application of past experience, we should be able to soon answer some of the questions about Treponema pallidum and the disease. With the right treatment, finally, after the right diagnosis, PC was able to make a recovery. The other women and the common partner did receive some treatment, and presumably they did recover some. Thanks so much for watching. Take care of yourself and be well.